Hello friends, welcome to NEET PG Live Daily. Myself Dr. Apoorva Mittal and I am your educator for anesthesia on this prestigious platform of Unacademy, and today we'll be discussing about yet another topic, that is important drugs in anesthesia. Yesterday I spoke about important drugs in anesthesia part 1, in which I covered the important IV induction agents which I used, and those all drugs, the 5 drugs which I covered yesterday, those are very important. Okay, so let's continue that topic, that is important drugs in anesthesia. But before that, welcome to Unacademy friends, and by getting the Unacademy Plus subscription, you'll be able to avail all the live classes for the 19 subjects and also interact with the educator. And also we'll be having daily test series and analysis in which you can evaluate your progress, and you can also come to know what kind of questions are asked in the exams. And also we'll be having live doubt clearing sessions through which you can clear that doubt pertaining to the subject. So that are all that is all the advantages of the Unacademy Plus subscription. Okay, and that if you avail for 12 months or 24 months, and if you apply my code, that is Apoorva Live, APOORVA Live, you can get a 10% discount on the above courses. So let's start our today's topic, that is important drugs in anesthesia part 2. Dr. Arjun, welcome to the class, and if any doubts please let me know. Okay, so let's discuss with local anesthetics first. Okay, so today I'll be discussing about the local anesthetics and the skeletal muscle relaxants. Yesterday I spoke about the IV induction agents. Okay, Dr. Arjun, I hope I'm loud and clear. If any doubts, please let me know. So first of all, coming to the local anesthetics. Okay, what is the mechanism of action of the local anesthetics? Many questions are asked from this topic also. First of all, what is local anesthetic? Local anesthetic is a drug when it is infiltrated around the nerve, okay, supplying a particular area, only that nerve will get anesthetized. Okay, it causes reversible, okay, very important, it causes reversible loss of the motor, sensory or autonomic functions from the nerve, around the nerve in which it is, around which it is infiltrated. So that is what is a local anesthetic. एग्जाम्पल जैसे लिग्नोकेन, ठीक है, लिग्नोकेन आप लोगों ने देखा होगा, ब्यूपीवाकीन. These are the examples of the commonly used local anesthetic. Now, how these local anesthetic work? ठीक है, the mechanism of action of the local anesthetic. See, first of all, please understand how a action potential is generated in a nerve fiber, and then how these local anesthetics are stopping the impulse to be transmitted or conducted. ठीक है, जो इम्पल्स जनरेट हो रहे हैं उसको कैसे ये कंडक्शन होने से बचा रहे हैं, दैट इज हाउ द लोकल एनेस्थेटिक वर्क. सो इफ दिस इज अ न्यूरॉन, ठीक है, रेस्टिंग मेम्ब्रेन पोटेंशियल, ओके, रेस्टिंग मेम्ब्रेन पोटेंशियल में क्या होता है, यहाँ पे नेगेटिव चार्ज होता है, यहाँ पे पॉजिटिव चार्ज होता है, ठीक है. दिस नेगेटिव चार्ज इनसाइड is because of 2 reasons. The negative charge, okay, the negative charge inside the neuron in the resting membrane is because of 2 reasons. One is because of the sodium potassium ATPase pump, okay, which is an energy dependent pump. ATPase aa gaya, it is an energy dependent pump. What it does is during the resting state, it pumps 2 potassium in and 3 sodium out. ठीक है, तो इसकी वजह से बिकॉज इट इज पंपकिन, ठीक है, इसको कैसे याद रखेंगे, पंपकिन, पंपकिन, है ना. तो रेस्टिंग मेम्ब्रेन पोटेंशियल, रेस्टिंग स्टेट में क्या हो रहा है, देयर इज नेगेटिव चार्ज इनसाइड. inside the ICF, and outside it is positive charge. How is it? That is because of two reasons. First, because of the sodium potassium ATPase pump. ठीक, उससे क्या हो रहा है, दो पोटेशियम अंदर आ रहे हैं तो तीन सोडियम बाहर जा रहे हैं. प्लस ये जो मेम्ब्रेन है इट इज मोर लीकी टू पोटेशियम. ठीक है, एज कंपेयर टू सोडियम. ठीक है, तो सम अमाउंट ऑफ पोटेशियम फ्रॉम इनसाइड इट गोज आउटवर्ड ऑल्सो. सो अंदर नेगेटिव चार्ज ज्यादा होता है, बाहर पॉजिटिव चार्ज ज्यादा होता है. दैट इज इन केस ऑफ द रेस्टिंग मेम्ब्रेन पोटेंशियल. नाउ व्हाट हैपेंस व्हेन अ स्टिमुलस इज अप्लाइड. ठीक है, स्टिमुलस इज अप्लाइड, यही जो मेम्ब्रेन है इसके ऊपर वोल्टेज गेटेड चैनल्स होते हैं. देयर आर वोल्टेज गेटेड चैनल्स. तो जैसे वोल्टेज गेटेड सोडियम चैनल्स हुए. रेस्टिंग स्टेट में तो ये चैनल्स क्लोज रहते हैं. ठीक है, ये चैनल्स क्लोज रहते हैं. मगर जब स्टिमुलस अप्लाई होता है, ये जो सोडियम वोल्टेज गेटेड सोडियम चैनल्स होते हैं ये खुल जाते हैं. उसकी वजह से देयर इज इनफ्लक्स ऑफ द सोडियम. ठीक है, whenever there is influx of the sodium, अंदर क्या हुआ, पॉजिटिव चार्ज, बाहर comparatively नेगेटिव चार्ज. So this part of the membrane gets depolarized. And when the threshold is reached, action potential is generated and there is conduction of the nerve impulse. Understood. There are various channels, the voltage gated sodium potassium channels on the membrane. ठीक है, मेनली जब स्टिमुलस अप्लाई होते हैं तो क्या होता है, ये जो सोडियम चैनल्स हैं जो क्लोज रहते हैं, दे ओपन अप. And as they open up, what happens? There is influx of the sodium. And there is depolarization of the membrane. Dr. Anish, welcome to the class. Dr. Arjun, is it clear? Dr. Anish, if any doubts, please let me know. Okay. So this is how the depolarization of the membrane takes place. ठीक है. Now what happens, जब हम लोगों लोकल एनेस्थेटिक को क्या करना है, लोकल एनेस्थेटिक को इसी कंडक्शन को ब्लॉक करना है. So what happens, local anesthetic, remember local anesthetic, it is a weak base. ठीक है, local anesthetic, it is a weak base. I'll change my color. ठीक है, so what happens here, okay, here the pH is around 7.4. Here the pH outside, that is in the ECF, the pH is around 7.4. Okay, and inside it is around 7.2. And the pKa, what is pK? It is a dissociation constant. In which the ionized component is equal to the unionized form. है ना? So the pKa of local anesthetic, that is around 8 to 9. ठीक है, तो in this pH 7.4, it will be present more in the ionized form and less in the unionized form. मगर ये जो unionized form है, unionized form of the local anesthetic, it is the one which can permeate this membrane. ठीक है, and once it permeates this membrane in the unionized form, remember local anesthetic is permeating the membrane. ठीक है, it is permeating ये जो membrane है in what form? In unionized form. And when it permeates the membrane in unionized form, because here the pH is lesser, it reacts with the hydrogen ion and converts into the cationic or the ionized form. And this ionized form, it blocks these sodium channels, the voltage gated sodium channel. और ये जब इसको सोडियम चैनल को ब्लॉक कर देता है तो क्या होगा? देयर वोंट बी एनी इनफ्लक्स ऑफ द सोडियम इवन व्हेन स्टिमुलस इज अप्लाइड एंड देयरफॉर the conduction of impulses does not take place. Is it clear? Is it clear? Dr. Arjun, Dr. Anish, is it clear? Any doubts in this? So what we have to remember, I'm so sorry. Okay, so what we have to remember in this, the local anesthetic, it is what? It is a weak base. Okay, the local anesthetic, it is a weak base. It permeates the membrane in what form? In the unionized or the non-ionized form, and when it permeates in the cytoplasm, in the cytoplasm it is converted into the cationic form, and it is this cationic form which blocks these sodium channels, and therefore influx of the sodium does not take place and there is interruption of the nerve impulse. Is it clear? Is it clear? Dr. Arjun, Dr. Anish, any doubts? Any doubts in this? Okay, so if it is asked, the local anesthetics, they have greater affinity, they have greater affinity for the channel in the open state or what is known as the inactivated state C. ये जो सोडियम चैनल्स हैं, ठीक है, सोडियम चैनल्स हैं, okay, these are present in 3 states. Okay, so if I say the sodium channels, these are present in 3 states. One is the resting state, ठीक है, one is open and one is inactivated state. ठीक है, रेस्टिंग स्टेट में क्या होता है? बोथ द अपर एंड द लोअर गेट्स आर क्लोज्ड. ठीक है, बोथ द गेट्स आर क्लोज्ड व्हिच हैपेंस इन द रेस्टिंग मेम्ब्रेन पोटेंशियल रेस्टिंग स्टेट. Open when the stimulus is applied, both these gates open up and there is influx of the sodium that is happening in the open state. मगर ये जो सोडियम चैनल्स हैं, ठीक है, they open for a very short period of time. They open only for 1 milliseconds and after that they enter into the inactivated state, that is in the refractory state. Okay, that is in the refractory state. At this stage, even if the stimulus is applied, there is no generation of the action potential, है ना? So the local anesthetics, क्योंकि क्या है, ये सोडियम चैनल्स को अंदर से ब्लॉक करते हैं, ठीक है, तो they have greater affinity for the channels when they are in the open or the inactivated state rather in the resting state. ठीक है, and blockade develops, remember this point also, blockade develops rapidly when the nerve stimulus is applied repeatedly, क्योंकि जितना बार हम लोग उसको स्टिमुलस देंगे उतनी बार वो ओपन स्टेट में जाएगा और लोकल एनेस्थेटिक आर मोर इफेक्टिव इन द ओपन स्टेट. Therefore they are frequency dependent also. Is it clear? So therefore degree of blockade is frequency dependent, that is greater blockade at higher frequency of stimulation. Is it clear? Dr. Arjun, Dr. Anish, is it clear? Is it clear? Any doubts? Okay. So local anesthetics, these are weak bases. They penetrate the membrane in the non-ionic form. Okay. They block the voltage gated sodium and time dependent sodium channels from the inner surface in the cationic form, and degree of blockade is frequency dependent, So that is what you have to remember about the local anesthetic. Okay, all these points you have to remember about the local anesthetic. Okay, so another important question which is asked to you, I discussed the local anesthetic mechanism of action in detail because many questions are asked. Another important question which is asked is factors that can affect the penetration of axonal membrane by local anesthetic. Okay, there are certain factors which affect the penetration. So, Dr. Arjun, can you tell me, if I increase the pH, okay, if I increase the pH of the outside environment, what will happen? If I increase the pH of the outside environment, what will happen? More of the local anesthetic will be present in the non-ionized form. If I increase the pH of the outside environment, more will be present in the non-ionized form, and more easily it will penetrate the membrane. It will penetrate the membrane. Okay? So how is it done? That is done by adding soda bicarb to the local anesthetic. So by adding the soda bicarb to the local anesthetic, what I am doing is I am increasing the pH. I'm increasing the pH, and therefore more amount of it is present in the non-ionized form, and it can easily penetrate the membrane. Okay, what happens if it is an acidic environment? Acidic environment, for example, whenever there is an infection, ठीक है, या फिर पस है, तो बाहर का यहाँ का pH क्या होगा? It will be decreased. So more will be present in the unionized form, and therefore it will be difficult for it to penetrate the membrane. It will be difficult for it to penetrate the membrane. Is it clear? Therefore, it takes a longer time for the local anesthetic to work in the environment where the infection is present or the pus is present. अगर उस area में pus present होगा, local anesthetic will take longer time to act. Is it clear? Okay. Okay. Now coming to the structure of the local anesthetic, this is important because depending upon the local anesthetic, if it is amide or ester form, they have different features. Therefore, you should remember this. Okay. So just remember the structure of the local anesthetic. The local anesthetic, it has a lipophilic group. It has a lipophilic group and a hydrophilic group. ठीक है, एक उसके पास लाइपोफिलिक ग्रुप है और हाइड्रोफिलिक ग्रुप है, और इसके बीच में जो लिंकेज है, ठीक है, इन दोनों के बीच में जो लिंकेज है, इट कैन बी आइदर एस्टर और इट कैन बी आइदर अमाइड. ठीक है, इफ दिस लिंकेज इज ऑफ द एस्टर, ठीक है, then it is known as the ester amino local anesthetic, and if it is amide, then it is a amide local anesthetic. Okay, so based on the chemical structure, they are amino esters and amino amides. ठीक है, esters and amides. Okay, now esters में एक भी I नहीं आया, so the examples of this contains only one I. Remember this. ठीक है, the local anesthetics in which only one I is present, those are the examples of amino esters. If two I's are present, because amide has an I, if two I's are present, these are the example of amides. These are an example of amides. So this is very important. Based upon the chemical structure, these are divided into amino esters or amino amides. तो एस्टर्स के एग्जाम्पल क्या हो गए? प्रोकेन, क्लोरप्रोकेन, बेंजोकेन, कोकेन. जबकि जिस भी नाम में दो आई आ रहे हैं, लाइक लिग्नोकेन, प्राइलोकेन, ब्यूपीवकेन, डिब्यूकेन, दीज आर द अमाइनो अमाइड्स. ठीक है, दीज आर द अमाइनो अमाइड्स. नाउ व्हाई डू वी हैव टू रिमेंबर, जो ये एस्टर्स होते हैं, ये जो एस्टर्स होते हैं, क्वेश्चन आता है, दीज आर मेटाबोलाइज्ड बाय सूडोकोलिनेस्टरेज. These are metabolized by pseudocholinesterase. Can you please tell me another example of drugs? Dr. Arjun, Dr. Anish, tell me example of drugs, other drugs which are metabolized by pseudocholinesterase enzyme. The other drugs which are used in anesthesia metabolized by pseudocholinesterase enzyme. Can you tell me? See, we know the esters local anesthetic, these are metabolized by pseudocholinesterase. The other drugs in anesthesia, used in anesthesia, which are metabolized by pseudocholinesterase are scoline, okay, mivacurium. Please remember this, okay, remifentanil. These are the other drugs in anesthesia which are metabolized by pseudocholinesterase. Remember Remember, all the amino esters local anesthetics are metabolized by pseudocholinesterase except cocaine. ठीक है, except cocaine. Cocaine is metabolized in the liver. ठीक है, जबकि ये जो अमाइड्स होते हैं, अमाइड्स फॉर्म होते हैं, these are metabolized by N-dealkylation and hydroxylation in the liver by cytochrome P450. Okay, so these are metabolized by pseudocholinesterase and these are metabolized by N-dealkylation and hydroxylation in liver by cytochrome P450. Okay, now amino esters, there is higher incidence of allergic reaction. Always remember, they have higher incidence of the allergic reaction. Amides may they have low incidence of the allergic reaction, and esters, they are not bind to the plasma protein and therefore they are short acting, but amides they bind to the alpha 1 acid glycoprotein. तो एस्टर से क्या क्या याद रखना है? Pseudocholinesterase enzyme except cocaine, higher incidence of allergic reaction, and also they are not bind to the plasma protein. They are not bind to the plasma protein. Is it clear? Is it clear? No. I told you this. Okay, now coming to the local anesthetics which are commonly used and asked, basically which are asked. Cocaine first point, ये अमाइड है कि एस्टर है? इट इज एन एस्टर. ठीक है, दूसरा क्या याद रखना है? इट इज हाइड्रोलाइज्ड इन द लिवर. ये दोनों पॉइंट्स तो याद रखने ही हैं. फ्रॉम कोकेन ओल्डेस्ट and only, अगर क्वेश्चन है only naturally occurring local anesthetic, that is cocaine. Okay, cocaine is the only naturally occurring local anesthetic. ठीक है, ज्यादातर इसको टॉपिकल एनेस्थीसिया में, एंड रिमेंबर only anesthetic who has a vasoconstrictor property, and therefore it is never ever given intravenously. Cocaine should never be given intravenously because it is vasoconstrictive in nature and also sympathomimetic in nature. Because क्या पढ़ा है फार्मा में? Because it inhibits the reuptake of adrenaline and noradrenaline and therefore it has a sympathomimetic effect. ठीक है, तो कोकेन से क्या क्या याद रखना है? एस्टर. ठीक है, मेटाबोलाइज कहाँ पे? लिवर. ओल्डेस्ट naturally occurring, only local anesthetic with vasoconstrictor property and sympathomimetic effect. Is it clear? Is it clear? Any doubts in this? ठीक है, कोकेन से ये सारे पॉइंट्स याद रखने हैं. प्रोकेन से क्या याद रखना है? फर्स्ट सिंथेटिक लोकल एनेस्थेटिक. और प्रोकेन, ठीक है, क्या याद किया था हम लोगों ने? जितने भी एस्टर्स अमाइनो एसिड्स होते हैं, दे आर एलर्जिक, है ना, एलर्जिक. सो व्हाई दे कॉज एनाफिलैक्टिक रिएक्शन? प्रोकेन एंड दूसरा क्वेश्चन आता है बेंजोकेन. ठीक है, प्रोकेन एंड बेंजोकेन, what happens? They are metabolized to para-aminobenzoic acid. What are they? They are metabolized to para-aminobenzoic acid. Remember, ठीक है, प्रोकेन and benzocaine metabolized to para-aminobenzoic acid, and therefore there is rare anaphylactic reaction. And remember, local anesthetic of choice in malignant hyperthermia is procaine. Yesterday we studied that propofol can be used in cases of malignant hyperthermia. और अगर local anesthetic पूछा जाए तो that is a procaine. Is it clear? Is it clear? Dr. Arjun, Dr. Anish, is it clear? Others, is it clear? Any doubts? Please let me know. Okay. ठीक है, क्लोरप्रोकेन से हमें क्या याद रखना है? क्लोरप्रोकेन, अगर क्वेश्चन है शॉर्टेस्ट एक्टिंग लोकल एनेस्थेटिक, तो इट इज शॉर्टेस्ट एक्टिंग. तो ये तो हम लोगों को बहुत फ्रीक्वेंटली यूज होना चाहिए था, है ना, क्योंकि शॉर्टेस्ट एक्टिंग लोकल एनेस्थेटिक है. फॉर वेरी स्मॉल प्रोसीजर्स दिस शुड हैव बीन यूज्ड, बट The problem is it caused it when it was used for spinal anesthesia. When it was used for spinal anesthesia, it used to cause paraplegia, and therefore this chlorprocaine was withdrawn. Okay, and it was found that chlorprocaine, because of its preservative, ठीक है, उसमें जो प्रिजर्वेटिव था सोडियम मेटाबाइसल्फाइड, it was the one which was producing this allergic reaction. This sodium metabisulfite was the one which was producing this allergic reaction, and now it has been reintroduced, but preservative free. The question can be asked, the preservative used in chlorprocaine which used to cause paraplegia, that is sodium metabisulfite. ठीक है, अब प्राइलोकेन से हम लोग कहाँ आ गए, हम लोग अमाइड्स पे आ गए. ओके, अमाइड लोकल एनेस्थेटिक. ठीक है, these are metabolized to O-toluidine, and this can cause methemoglobinemia. It can cause methemoglobinemia, and treatment is methylene blue. Coming to एमला पे लास्ट ईयर भी अभी एम्स में क्वेश्चन पूछा गया है. ठीक है, आमला, इट इज अ यूटेक्टिक मिक्सचर ऑफ व्हाट? It is a eutectic mixture of lignocaine and prilocaine. ठीक है, lignocaine and prilocaine. टॉपिकल एनेस्थेटिक है, कहाँ यूज होता है? टू प्रिवेंट IV cannula pain. It is used to prevent the IV cannula pain. So these are the examples of the amide local anesthetic. Coming to lignocaine, is it clear? Doubts? Any doubts? Any doubts? Please let me know if there are any doubts. Okay. What about lignocaine? Lignocaine, it is the most common used local anesthetic. Lignocaine is the most common used anesthetic. इसमें different concentrations are there which are used for different types of anesthesia. For example, अगर हम लोग lignocaine spinal anesthesia, remember spinal anesthesia के लिए it is 5%, sorry, spinal anesthesia के लिए it is 5%. मगर जो lignocaine jelly होती है, जो topical application के लिए यूज करते हैं, it contains 2% of lignocaine. ठीक है, so just remember that lignocaine, it is the most commonly used local anesthetic and it has different concentrations. ठीक है, it has different concentrations. For example, spinal anesthesia, remember it is 5%, जबकि जो topical lignocaine jelly होती है, that is 2%. Now with the lignocaine में याद रखना, the systemic toxicity of lignocaine is less than bupivacaine. What does it mean? See, the CCNS ratio, that is the minimum amount of drug that causes CVS depression. ठीक है, upon the minimum amount of drug. Dr. Ashish, welcome to the class. Good evening. If any doubts, please let me know. I hope till now it was clear. ठीक है, तो systemic toxicity of lignocaine is less than that of the bupivacaine. The CCNS ratio is 7. That means the minimum amount of drug that causes the CVS depression upon the drug that causes depression of the nervous system. ठीक है, central nervous system. So if the ratio is more, that means if nervous tissue toxicity अगर वो produce करने के लिए, nervous system toxicity अगर उसको produce करने के लिए 1 ml चाहिए, तो CVS toxicity produce करने के लिए उसको 7 ml चाहिए. ठीक है, जबकि bupivacaine का CCNS ratio is less, that is only 3. ठीक है, ब्यूपीवकिन का CCNS रेशियो इज लेस, सो लेस अमाउंट ऑफ ड्रग इज प्रोड्यूसिंग CVS टॉक्सिसिटी, देयरफॉर इट इज मोर टॉक्सिक देन दैट ऑफ द लिग्नोकेन. ठीक है, Dr. SG CCNS ratio, minimum amount of drug that produces CVS cardiovascular toxicity upon the CNS toxicity. ठीक है, is it clear? तो लिग्नोकेन का CCNS ratio is 7. It is 7. So less amount of drug is used to produce the CNS toxicity as compared to the CVS toxicity. Okay. Whereas in bupivacaine, even small amount of drug can cause CVS toxicity, that is systemic toxicity. Is it clear? Is it clear? So CNS tox involvement, okay, CNS involvement in lignocaine occurs at a much lower dose than the CVS involvement because the CCNS ratio is 7. अच्छा, हम लोग प्रोकेन क्यों यूज कर रहे थे? We were using procaine for malignant hyperthermia, है ना, but lignocaine can precipitate malignant hyperthermia. ठीक है, the local anesthetic that can precipitate malignant hyperthermia, that is lignocaine. ठीक है, which is used in malignant hyperthermia is procaine. ठीक है, now lignocaine L. ठीक है, maximum safe dose if it is asked without adrenaline. ठीक है, adrenaline क्या है? It is a vasoconstrictor. So when, if this is the nerve tissue, उसके सराउंडिंग क्या होगा? ब्लड वेसल्स भी प्रेजेंट होंगे. ठीक है, when I am giving the drug over here, some amount of it will be absorbed by the nervous tissue, but some amount of drug will go into the blood vessels also, and that can cause systemic toxicity. Okay, local anesthetic, systemic toxicity. Now, if I am adding adrenaline, what will happen? ये जो blood vessel है, that will get vasoconstricted. It will get constricted. तो क्या होगा? More amount of drug will be available to act on the nervous tissue, and less amount of it will be absorbed by the blood vessels. Therefore, chances of systemic toxicity is less. ठीक है, so whenever lignocaine is given without adrenaline, then the dose is only 4.5 milligram per kg, the maximum safe dose. But when I'm adding vasoconstrictor, I can increase the maximum safe dose to 7. So with adrenaline, remember this is lignocaine L, maximum safe dose is 7. And from this 7, remember the CCNS toxicity ratio. The CCNS ratio is also 7. Is it clear? Dr. Ashish, Dr. SG, Dr. Arjun? Is it clear? Any doubts in this? Any doubts? Please let me know. Okay. Another question asked in lignocaine in this is, what are the other uses of lignocaine? So the other uses are, it is used to treat the ventricular arrhythmias and also blunt the cardiovascular response to laryngoscopy and intubation. Okay, so other uses treat ventricular arrhythmias and also cardiovascular response to laryngoscopy and intubation. Okay. Now another important local anesthetic जो आप लोगों ने OTs में देखा होगा, mostly used for the spinal anesthesia or the peripheral nerve block, that is bupivacaine. Okay, that is bupivacaine. It is also known as sensoricaine or marcaine. Bupivacaine is also known as sensoricaine or marcaine. It is the second most commonly used local anesthetic after lignocaine. ठीक है, and concentration इसमें याद रखना, spinal के लिए we are using 0.5%. Lignocaine we were using 5%, but bupivacaine we are just using 0.5%. ठीक है, but it is more cardiotoxic than, it is the most cardiotoxic local anesthetic. I told you because the CCNS ratio is only 3 and maximum safe dose is 3 milligram per kg. 3 milligram per kg. So that is the difference. Okay. Now, I told you that bupivacaine is cardiotoxic in nature. Why? Because bupivacaine has two forms. It's a racemic mixture of R and S form. It is this R form which is responsible for cardiotoxicity. ठीक है, तो हम लोगों ने क्या किया, इसका एक वो सब्स्टिट्यूट दैट इज लिवोब्यूपिवकिन. लिवोब्यूपिवकिन इट इज अ एस एनांशियोमर ऑफ ब्यूपिवकिन. ठीक है, तो आर फॉर्म हटा दिया, इट इज ओनली द एस एनांशियोमर ऑफ ब्यूपिवकिन एंड इट इज लेस कार्डियोटॉक्सिक. It is less cardiotoxic and less prone to cause seizures as compared to bupivacaine. Is it clear? Is it clear, friends? Any doubts in this? ठीक है, तो bupivacaine it has two forms, R and S. It was the R form which was responsible for cardiotoxicity. तो हमने क्या किया, लिवोब्यूपिवाकेन. लिवोब्यूपिवाकेन और ब्यूपिवाकेन में क्या डिफरेंस है? लिवोब्यूपिवाकेन it is the S enantiomer, and as it is S enantiomer, it is less cardiotoxic and it is more prone to cause the seizures. Less prone to cause the seizures. Similarly, ropivacaine is also S enantiomer. It is also S enantiomer. इसमें जो एलिफैटिक ग्रुप होता है, ठीक है, ब्यूपिवाकेन में इट हैज लार्ज एलिफैटिक ग्रुप ऑफ ब्यूटाइल. ठीक है, रोपिवाकेन का जो एलिफैटिक ग्रुप होता है दैट इज प्रोपाइल साइड चेन. ठीक है, इसमें प्रोपाइल साइड चेन होता है एंड therefore the penetration into the nerve fibers is less. ठीक है, penetration, the lipophilicity is less. ठीक है, it is less lipophilic than bupivacaine and therefore remember, less likely to penetrate the large myelinated motor nerve fibers. और इस फीचर को हम लोग कहाँ यूज करते हैं? इस फीचर को हम लोग वॉकिंग एपिड्यूरल और लेबर एनाल्जेसिया के लिए यूज करते हैं. Therefore it is a drug of choice for labor analgesia or epidural anesthesia in walking epidural. ठीक है, because ropivacaine का जो side chain है that is less. Okay, it is a propyl side chain and therefore it is less lipophilic than bupivacaine and उसका जो penetration है into the large myelinated fibers it is less and therefore but इसका जो और component है sensory और autonomic, तो हमें क्या चाहिए? During labor the lady should be able to push properly मगर उसको, ठीक है, pain नहीं होना चाहिए. ठीक है, so the sensory and the autonomic block is same but the motor block is less and therefore it is used in labor analgesia. Is it clear? Is it clear? Any doubts? Sorry. Any doubts, friends? If any doubts, please let me know. The uses of local anesthetic अगर पूछा जाए तो topical anesthesia के लिए, ठीक है, lignocaine and tetracaine, local infiltration and peripheral nerve block like bupivacaine, ropivacaine, lignocaine, ठीक है, intravenous bias block, ठीक है, short acting like chlorprocaine and lignocaine, spinal के लिए bupivacaine, lignocaine, ropivacaine and epidural. ठीक है, so I hope the local anesthetics questions asked from local anesthetic is what is the mechanism of action, what are the factors that can affect, and they can ask you about the different local anesthetic that have covered in this. Okay, that have covered in this. Is it clear? Any doubts in local anesthetics? Any doubts in local anesthetics? Okay, now coming to the second group of most important drugs which are used in anesthesia, that is the skeletal muscle relaxants. Okay, now the skeletal muscle relaxants, what happens? See, This is the nerve fiber. Okay, this is the nerve fiber. This is the synaptic knob, and this is the muscle fiber. Okay, here is the neuromuscular junction. Here is the neuromuscular junction. Now, whenever the impulse comes, okay, what happened? This impulse is propagated to the dendrites. ठीक है, dendrites, और यहाँ पे dendrites में synaptic knobs होते हैं. ठीक है, और इसको अगर मैं zoom करूँ तो ये क्या हो गया, एक synaptic knob हो गया, which is the nerve terminal. ठीक है, इधर क्या होता है, synaptic vesicles होते हैं. ठीक है, इधर क्या होता है, synaptic vesicles होते हैं. ये synaptic vesicles के अंदर क्या होता है, that is acetylcholine. That is acetylcholine. So whenever a nerve impulse comes, whenever the nerve impulse comes, what happens? There is voltage gated calcium channels here. Voltage gated calcium channels. Through this, the calcium influx takes place, and this calcium, it causes these synaptic vesicles to fuse to this membrane. And there is release of the acetylcholine. Okay, and this acetylcholine, it reacts on the acetylcholine receptors, which is present on the membrane, okay, the muscle membrane. And when they react, there is configurational change in the acetylcholine receptors. Okay, and there is opening of the sodium channels, the influx of the sodium takes place, and therefore action potential is generated. And the nerve impulse is conducted. Is it clear? Any doubt in this? तो क्या हुआ, ये सिनेप्टिक नॉब है, इसके अंदर सिनेप्टिक वेसिकल्स हैं, इसके अंदर क्या है, एसिटाइलकोलिन है, यहाँ से इम्पल्स आया, कैल्शियम चैनल्स ओपन हुए, इन्फ्लक्स ऑफ द कैल्शियम हुआ. ठीक है, दीज विल फ्यूज, दैट विल रिलीज द एसिटाइलकोलिन इनटू द न्यूरोमस्कुलर जंक्शनल स्पेस. ठीक है, ये मसल फाइबर है, इसके अंदर एसिटाइलकोलिन रिसेप्टर्स हैं. ठीक है, विच इज पेंटामेरिक इन नेचर. ठीक है, ओके, these will act with the acetylcholine receptors, and there will be influx of the sodium, and therefore the impulse conduction will take place. Ye sodium, it will bring about the configurational change, the calcium will be released, and there will be contraction. Okay, so that is what happens. Now, normally ye jo acetylcholine which is released and which is acting on this on the acetylcholine receptor, normally it is hydrolyzed by acetylcholinesterase enzyme, and it gets converted into acetate and choline. And when it occurs, the receptor ion channel, it closes, and the end plate repolarization takes place, and the muscle relaxes. Is it clear? सोडियम जब इन्फ्लक्स हो रहा था तो क्या हो रहा था, डीपोलराइजेशन हो रहा था, और उसके बाद मसल का कॉन्ट्रैक्शन हो रहा था. ठीक है, मगर नॉर्मल स्टेट में क्या होता है, ये जो एसिटाइलकोलिन होता है, इट इज हाइड्रोलाइज्ड बाय द एसिटाइलकोलिनेस्टरेज एंजाइम, एंड the end plate will repolarize, and there will be muscle relaxation. Now, the depolarizing and non-depolarizing muscle relaxants. ठीक है, अब depolarizing का क्या मतलब हुआ, they are causing the depolarization of the muscle membrane. ठीक है, अगर ये मसल मेम्ब्रेन का डीपोलराइजेशन कर रहे हैं, फॉर एग्जाम्पल सक्सिनाइलकोलिन और सक्सामिथोनियम, दूसरा नाम इसका है सक्सामिथोनियम. ठीक है, ये क्या करता है, दिस इज द सिनेप्टिक नॉब. ठीक है, और these are the acetylcholine receptors. अब ये जो सक्सिनाइलकोलिन है, what it does, it closely resembles the structure of the acetylcholine. ठीक है, तो it closely resembles the uh, structure of the acetylcholine and it has sub-maximum intrinsic activity on the NM receptor. तो succinylcholine ये क्या करेगा, ये जो निकोटिनिक रिसेप्टर्स है इसके साथ जाके बाइंड कर जाएगा, and as the structure is same as that of the acetylcholine, there will be ठीक है, there will be opening of the sodium channels and that will depolarize the muscle end plate. अगर ये depolarize कर रहा है तो मसल को contract होना चाहिए था, ठीक है, but what happens is this succinylcholine is not, it is not metabolized by the acetylcholinesterase enzyme, ठीक है, and as it is not metabolized by the acetylcholinesterase enzyme, it does not dissociate rapidly from the receptor and therefore there is persistent partial depolarization. ठीक है, persistent partial depolarization, the membrane, it goes into the refractory stage and further stimulus cannot act on it and the sodium channels get inactivated and therefore there is flaccid paralysis. Is it clear? So succinylcholine, it is a depolarizing muscle relaxant. It depolarizes the membrane but and therefore there is partial twitching and fasciculations. But what it does is it does not dissociate from the receptor and therefore there is persistent partial depolarization, okay, and therefore it causes flaccid paralysis. Is it clear? Is it clear? Now, non-depolarizing muscle relaxants, for example, etracurium, rocuronium, ठीक है, तो क्या हुआ, वो क्या हुआ, agonist हुआ, non-competitive agonist. ये क्या हुआ, non-depolarizing, they are non-competitive antagonist. ठीक है, इसका structure is entirely different from acetylcholine. ठीक है, जब हम ये दे रहे नॉन डिपोलराइजिंग मसल रिलैक्सेंट्स, they go and bind to this acetylcholine receptors, ठीक है, they go and bind to the acetylcholine receptors and therefore there is configurational change. कॉन्फ़िगरेशनल चेंज होगा तो क्या होगा, एसिटाइलकोलिन इसके साथ बाइंड नहीं कर पाएगा and therefore ion channel opening does not occur, and as it does not occur the depolarization membrane does not occur. Is it clear? तो यहाँ पे because of the configurational change, ठीक है, because they act on the acetylcholine receptors, there is configurational change, acetylcholine cannot bind to it and therefore depolarization of the membrane does not happen. ठीक है, ये तो हो गया पोस्ट सिनेप्टिक. ठीक है, यहाँ पे ये जो NDMRs होते हैं, they also act on the presynaptic nicotinic cholinergic receptors. Always remember, they also act on the ये जो blue color का presynaptic nicotinic cholinergic receptor and it is autostimulatory. मतलब ये जो presynaptic है, ठीक है, सम ऑफ द एसिटाइलकोलिन, ठीक है, यहाँ से ये जो रिसेप्टर्स हैं, दिस फर्दर कॉजेस द रिलीज ऑफ एसिटाइलकोलिन, ठीक है, दीज आर ऑटो स्टिमुलेटरी इन नेचर, ठीक है, एसिटाइलकोलिन खुद के रिलीज को स्टिमुलेट कर रहा था मगर एनडीएमआरस ने इनको भी ब्लॉक कर दिया, तो ये जो ऑटो स्टिमुलेटरी चैनल है ये भी वो हो गए, suppress हो गए, therefore release of the acetylcholine is reduced and therefore we get a fade phenomena with train of 4. ठीक है, therefore we get a fade phenomena with train of 4, which is a testing for the muscle relaxant. उसमें क्या होता है, as these are acting on the presynaptic area also, the autostimulatory action is gone. Is it clear, friends? Is it clear? Any doubt in this? Dr. SG, Dr. Ashish, Dr. Arjun, is it clear? If any doubts, please let me know. Okay. Now, what happens with the phase 2 block? That is the dual block which is seen with scoline. अगर मैंने स्कोलिन का हाई डोज दे दिया है, ठीक है, ठीक है, अगर मैंने उसको हाई डोज दे दिया, then it acts as a non-depolarizing muscle relaxant. नॉन डिपोलराइजिंग कहाँ कहाँ एक्ट करते हैं? दीज आर एक्टिंग ऑन द पोस्ट सिनेप्टिक, प्लस इट विल एक्ट ऑन द प्री सिनेप्टिक एरिया ऑल्सो. ठीक है, तो as it is acting on the presynaptic area also, therefore in the phase 2 block we see the fade phenomena even with succinylcholine. ठीक है, ठीक है, तो it results because of the desensitization of the receptor to the acetylcholine, and acetylcholine cannot act on the NM receptors, and they resemble the block produced by the competitive blockers. ठीक है, ठीक है. So this is very important. Phase 2 block is seen with the succinylcholine when it is given in a higher dose. Okay, there is desensitization of the acetylcholine receptors. Now, sequence of the muscle block. Remember, Dr. SG, you are asking me, ma'am, is it because of desensitization? The phase 2 block. In the phase 2 block, the succinylcholine is acting just like the non-depolarizing muscle relaxant. The non-depolarizing muscle relaxants, what they are doing? Non-depolarizing muscle relaxants, what they were doing? They were bringing the configurational change in these receptors, and therefore acetylcholine was not able to act on it. Okay, that is desensitization. Plus also succinylcholine in the phase 2 block. Okay, it is acting on the presynaptic membrane also, and because of the presynaptic membrane we are seeing the fade phenomena. तो succinylcholine जब ज्यादा उसमें दे दिया होता है, it is acting like NDMRs both on the postsynaptic membrane as well as presynaptic membrane. Is it clear? Dr. SG, is it clear? I think you are asking that the fade phenomena, is it because of desensitization? No, I'm telling that the phase 2, that is the dual block which we are seeing with succinylcholine, it acts same as the NDMS, that is desensitization of the postsynaptic receptors, plus it will act on the presynaptic receptors also, that will cause a fade block, fade phenomena. Is it clear, Dr. SG? Is it clear? Any doubts? Can I continue? Okay. So the sequence of the muscle block is, ठीक है, सबसे पहले muscle block कहाँ होता है? Face, jaw, pharynx, larynx. ठीक है, it is from up to down. ठीक है, तो face, jaw, pharynx, larynx, respiratory muscles, okay, trunk muscles, limb muscles, and the sequence of recovery is same as block. Okay, Dr. SG is asking me. Okay, Dr. SG and Dr. Prabhakar is asking me to repeat this, the phase 2 block. Okay, so I'll just repeat. See, Dr. SG, Dr. Prabhakar, the non-depolarizing muscle relaxants. Okay, the non-depolarizing muscle relaxants like atracurium, what it does is, okay, this is the synaptic vesicle. Sorry, this is the synaptic knob. Okay, and these are the acetylcholine receptors. Okay, these are the acetylcholine receptors. Whenever the stimulus comes, okay, ideally there is release of the acetylcholine, okay, into this area, into the neuromuscular junction, and it will act on these receptors, and that will cause influx of the sodium, and there will be depolarization of the membrane. Now, what happens when I have given NDMRs? Okay, these are the competitive antagonists. What they will do, these will go and bind to the acetylcholine receptors. Okay, when they will bind, there will be the structural change. And therefore acetylcholine cannot act on it. So basically it is causing desensitization. The receptors are becoming desensitized to the acetylcholine. And as acetylcholine cannot act on it, therefore there won't be any influx of the sodium, and therefore the impulse won't be conducted. ठीक है, तो that is on the postsynaptic. अब क्या होता है, प्री सिनेप्टिक मेम्ब्रेन में भी निकोटिनिक रिसेप्टर्स होते हैं, ठीक है, NN receptors. Okay, nicotinic receptors are present on the presynaptic membrane also. These nicotinic receptors ideally, normally क्या होता है, normally I'm telling, ये जो acetylcholine होता है, it will act on these receptors, it will also act on these receptors and will further cause release of the acetylcholine. So that is auto-stimulatory in nature. Acetylcholine खुद ही के release को increase कर रहा है. That is auto-stimulatory in nature. Now, what this NDMRs does is they block these receptors also. They block these presynaptic receptors also. Therefore, auto-stimulatory nature of the acetylcholine is also lost. And therefore, what we get fade phenomena, जो ये train of four, first stimulus, फिर second stimulus का जो result है वो कम होगा, third का result कम होगा, fourth का result कम होगा. This fade phenomena is seen because of this. This fade phenomena is seen because the presynaptic receptors are also blocked. Dr. SG, Dr. Prabhakar, अभी तक समझ में आया? Did you understand this point? Did you understand this point? Dr. SG, Dr. Prabhakar, please answer. Did you understand this point? Others, did you understand this? Okay. Okay. Now what happens in the phase 2 block? What happens in the phase 2 block that is seen with succinylcholine? It is seen with succinylcholine when it is given in higher dosage. Okay? What it does, it start acting like the NDMRs. तो NDMRs क्या कर रहे थे? NDMRs क्या कर रहे थे? They were acting on the postsynaptic receptors, and here they were causing desensitization, है ना? They were causing desensitization. Plus now as it is acting like NDMR, it will also act on the presynaptic autostimulatory receptors, and therefore we see the fade phenomena. So phase 2 blockade may, even if it is succinylcholine, we see the fade phenomena. Okay? Is it clear? Is it clear? Dr. Prabhakar, Dr. SG, is it clear? Any doubts in this? Any doubts in this slide now? Dr. Prabhakar, okay, you are clear. Dr. SG, is it clear? Okay, I think it is clear. Okay. Okay, so if it is asked, the fade phenomena is because it is acting on the presynaptic membrane also, and that is resulting in the fade phenomena. That is resulting in the fade phenomena. ठीक है? ठीक है? In succinylcholine, whenever we give succinylcholine, we see that there are fasciculations. So the first sign, the first clinical sign is fasciculation of the eyelid. It is the fasciculation of the eyelid. And in non-depolarizing blocker, the ptosis and diplopia, these occurs first, because the face muscles are the first which get anesthetized, which get relaxed. Is it clear? Is it clear, Dr. Pragya, Dr. SG, Dr. Prabhakar? Any doubts? Any doubts? Okay. So succinylcholine per se, succinylcholine क्या है? It is a depolarizing muscle relaxant. ठीक है? Depolarizing है, shortest and fastest acting, है ना? Shortest and fastest acting, and therefore it is used for induction also. It is shortest and fastest acting. Okay, it is the only MR. Remember, it is the only muscle relaxant which stimulates the autonomic ganglia and the vagus. Okay, and therefore bradycardia occurs due to vagus stimulation. Okay, it is the only muscle relaxant which stimulates the autonomic ganglia and vagus, and therefore bradycardia can occur with succinylcholine, and therefore whenever we are giving succinylcholine, we should always keep atropine in hand. Dr. Prabhakar, can you please be more specific what you didn't understand? Because I think you understood the fade phenomena and the dual blockade. Okay, please be more specific so that I can repeat for you. तो succinylcholine shortest and fastest acting, ये याद रखना है. ठीक है, it can produce bradycardia because of the vagal stimulation and therefore atropine should be used. ठीक है, it is rapidly hydrolyzed by plasma cholinesterase as I told you. ठीक है, and it can also, remember, it can precipitate malignant hyperthermia. तो आज हम लोगों ने 2 ड्रग्स पढ़े, लिग्नोकेन एंड स्कोलिन. ठीक है, it can precipitate malignant hyperthermia, and as it is shortest and fastest acting, therefore it is used in rapid sequence induction. Just remember that it can cause bradycardia. It can cause bradycardia because of the vagal stimulation. Okay, because it is a depolarizing, initially it will cause fasciculations and therefore there can be soreness of the muscles also. और ज़्यादातर patients क्या complain करते हैं from scoline, that there is post-operative muscle pain. ठीक है, post-operative muscle pain, which is a very common problem. Also because of this fasciculations and muscle contraction, initial muscle contraction, it can cause increase in the pressure, that is IOP, ICP and BP, and intra-abdominal pressure, and therefore in the closed eye surgeries, in the neurosurgeries, we often avoid using succinylcholine because it can aggravate these conditions. And I told you malignant hyperthermia, it can precipitate malignant hyperthermia, and therefore it should not be used in cases of malignant hyperthermia. So scoline, याद क्या रखना है? This is just a revision class. ठीक है, important drugs, scoline, depolarizing muscle relaxing, vagal stimulation, bradycardia. ठीक है, किससे मेटाबोलाइज होते हैं? थर्ड पॉइंट, प्लाज्मा कोलिनेस्ट्रेज, रिमेंबर. ठीक है, and can induce malignant hyperthermia. Also it causes post-operative myalgia because of the fasciculations. Now because it is causing fasciculations of the muscles, ठीक है, it can cause hyperkalemia also. ठीक है, so therefore, ठीक है, scoline, when the patient is already having hyperkalemia, scoline should not be used because it can further cause aggravation in this hyperkalemia and cause ventricular arrhythmias. It should be used very cautiously or should not be used in cases of the burn patients. Okay, burns till 1 year. Okay, in cases of the massive trauma because of rhabdomyolysis, anyway, because of the crush injury, potassium levels are anyways high, and scoline देंगे, it will further aggravate it and can cause ventricular arrhythmias. Okay, hemiplegia and paraplegia because of the muscle atrophy, because of the muscle damage, hyperkalemia, and also in the crush injury. So remember this, scoline, it causes hyperkalemia. ठीक है, can cause dangerous hyperkalemia. अगर पेशेंट का पोटेशियम लेवल नॉर्मल है, ठीक है, so a slight rise in potassium won't cause any harm. But if it anyways patient में पोटेशियम ज़्यादा है and if I'm using scoline, it can cause dangerous hyperkalemia and can cause ventricular arrhythmias. Is it clear? Scoline, is it clear? And I told you phase 2 block, ठीक है, that will cause prolonged apnea. ठीक है, phase 2 block I told you when it can happen, high dose में or else scoline किससे metabolize हो रहा है? It is metabolized by pseudocholinesterase. तो अगर pseudocholinesterase में कुछ प्रॉब्लम हुआ, atypical pseudocholinesterase होगा तो क्या होगा? Scoline ज़्यादा होगा and it can act as a phase 2 blocker. Okay, it can act as a phase 2 block. So phase 2 block or the prolonged block with scoline can be seen in 2 cases. Either you have given high dose or else there is atypical pseudocholinesterase enzyme. Is it clear? Is it clear? ठीक है. If by chance there is a scoline which is going into the phase 2 blockade, okay, if it is the patient is going into the phase 2 blockade, what should be the management? ठीक है, because he is not coming out of the skeletal muscle relaxant, तो हमें उसको respiratory muscles को support करना पड़ेगा and therefore continuous mechanical ventilation. ठीक है, और उसकी बॉडी से क्या करना है, उसकी बॉडी से हमें स्कोलिन वो जो एबनॉर्मल एबनॉर्मल सुडोकोलिनेस्ट्रेज है, एटिपिकल सुडोकोलिनेस्ट्रेज है, उसको कम करना है. तो इफ द पेशेंट इज नॉट रिकवरिंग फ्रॉम द फेज 2 ब्लॉक, वी शुड गिव FFP, रिमेंबर. ठीक है, we should give FFP, and this FFP will provide pseudocholinesterase to metabolize choline. Okay? The prolonged action of choline may you have to give mechanical ventilation to the patient, and if the patient is not recovering only, तो क्या करना है, हम लोगों को उसको FFP देना है, so that we give typical pseudocholinesterase which will metabolize this succinylcholine. Is it clear? Is it clear? Okay. Now what is Deboukin number? Another important question. ये जो atypical cholinesterase है, उसको measure करने के लिए कुछ तो होना चाहिए, है ना? तो this activity of atypical pseudocholinesterase is measured by Deboukin number. ठीक है? Deboukin, it is a local anesthetic. क्या है Deboukin? I told you it is a local anesthetic. कौन सा हुआ ये? A mild local anesthetic that inhibits 80% of normal pseudocholinesterase and only 20% of atypical pseudocholinesterase. ठीक है, तो Deboukin, it is a local anesthetic which will inhibit the normal pseudocholinesterase more than the atypical pseudocholinesterase, and this Deboukin number is used to measure the activity of atypical pseudocholinesterase. Is it clear? Succinylcholine is very important drug. Many questions are asked from this. Questions: depolarizing, phase 2 blockade, fasciculations, hyperkalemia, okay, treatment of phase 2 blockade, and Deboukin number. These all are the questions which are asked from the scoline. Dr. S.G., Dr. Prabhakar, Dr. Pragya, Dr. Ashish, Dr. Arjun, is it clear? Is it clear? ठीक है, ठीक है, तो वो था depolarizing muscle relaxants में. Now coming to the non-depolarizing muscle relaxants. ठीक है, non-depolarizing muscle relaxants, these are also of two types. एक तो बेंजाइल आइसोक्विनोलोन, ठीक है, और एक अमाइनो स्टेरॉइड डेरिवेटिव विच आर स्टेरॉइडल इन नेचर. Benzyl isoquinolones are the ones which we are using, like etracurium, cis-etracurium, mivacurium. ठीक है, these are the benzyl isoquinolone derivatives. ठीक है, remember benzyl isoquinolone derivatives like etracurium, cis-etracurium. Why I am emphasizing on this? Because these does not have any vagolytic action. एट्राक्यूरियम, सिस एट्राक्यूरियम, मिवाक्यूरियम में कोई भी वेगोलाइटिक एक्शन नहीं होता है, ठीक है, बट दे कॉजेस हिस्टामिन रिलीज. जबकि जो ये स्टेरॉइडल वाले हैं, पैंक्यूरोनियम, रॉक्यूरोनियम, ठीक है, वेक्यूरोनियम, ठीक है, इसमें क्या होता है, वेगोलाइटिक एक्शन is present except rocuronium or vecuronium. So you can say pancuronium has vagolytic action. Vagolytic action का मतलब क्या हुआ? It will cause I'm so sorry. Pancuronium, उधर you won't be able to see. ठीक है, pancuronium, it has a vagolytic action, and therefore that will cause increase in the heart rate. And in the conditions, like I can give you an example, जैसे mitral stenosis का patient है, anesthetic implication should be what? We should prevent tachycardia, and therefore in these cases pancuronium is not given. I'm just giving you an example. Okay, just remember this question can be asked from pancuronium. Because pancuronium has a vagolytic action, it causes increase in the heart rate. Mitral stenosis, I have already discussed in detail about this in anesthesia for special situations. Mitral stenosis के cases में we want to prevent tachycardia and therefore pancuronium is never used. ठीक है, it is never used. And ये जो steroidal होते हैं, they have very less propensity to cause histamine release. ठीक है, benzyl isoquinolones, histamine release. तो एट्राक्यूरियम से हिस्टामिन रिलीज होता है, मगर पैंक्यूरोनियम, रॉक्यूरोनियम, वेक्यूरोनियम से हिस्टामिन रिलीज नहीं होता. इज इट क्लियर? ठीक है. एट्राक्यूरियम क्या क्या याद रखा अभी हम लोगों ने? बेंजाइल आइसोक्विनोलोन. ठीक है, बेंजाइल आइसोक्विनोलोन क्या है? नॉन डिपोलराइजिंग मसल रिलैक्सेंट. तो क्या होगा? फेड फिनोमेना प्रेजेंट होगा. ठीक है, हिस्टामिन रिलीज होगा, वेगोलाइटिक एक्शन नहीं होगा. All these things we have remembered. Another important point is it undergoes Hoffman elimination. It is preferred in renal failure, liver failure, extremes of age group. Why? Because it undergoes Hoffman elimination. And what is Hoffman elimination? That is non-enzymatic degradation in the plasma. Okay, that is non-enzymatic degradation in the plasma. In exams, MCQ can be asked. Okay, all of the followings are metabolized or eliminated by liver or kidney except atracurium, cis atracurium. They undergo Hoffman elimination, that is non-enzymatic degradation in plasma, but 5% of it undergoes ester hydrolysis. Remember. ठीक है. Now atracurium से दूसरा पॉइंट क्या याद रखना है? इसका जो मेटाबोलाइज्ड फॉर्म है, ठीक है, प्रोडक्ट है, दैट इज लाउडोनोसिन. ठीक है, दैट इज लाउडोनोसिन. And this laudanocin can cross the blood-brain barrier and can cause seizures. So atracurium, Hoffman elimination 95%. Laudanocin, which can cross the blood-brain barrier and can cause seizures, and also histamine release. तो इन सब फीचर्स को हटाने के लिए हम लोगों ने क्या इंट्रोड्यूस किया? सिस एट्राक्यूरियम, है ना. So cis atracurium, it will keep the good points of atracurium, will eliminate the negative points. So what it is R cis enantiomer. Remember levobupivacaine और ropivacaine क्या थे? They were S enantiomers. Cis atracurium is R enantiomer. ठीक है, it is more potent. ठीक है, good point of atracurium इसने रख लिया Hoffman elimination. ठीक है, but 100% Hoffman elimination, it is not metabolized, hydrolyzed by plasma cholinesterase. ठीक है, no histamine release and less laudanocin. And as there is less laudanocin, therefore there is less CNS toxicity. Is it clear? ठीक है, these are the points that you have to remember. Dr. SG is asking, so ma'am, can we use it in CNS condition or in neurosurgery? Yes, atracurium and cis atracurium are used in neurosurgeries and CNS conditions because this laudanocin is seen in a very I haven't seen any reactions with this. ठीक है, atracurium के साथ I haven't seen, because of the laudanocin metabolite seizures formation, because this is in a very high concentration. Okay, whenever we are giving a very high dose of atracurium, then this metabolite is formed, then it will cause the blood-brain barrier. If we are using it cautiously, it is used in neurosurgery. Is it clear? But from theoretical point of view, just remember the atracurium metabolizes to laudanocin and it crosses the blood-brain barrier. This is more of theoretical part. ठीक है, more of theoretical part. Is it clear, Dr. SG? Is it clear? Okay. Now atracurium or cis atracurium को normally we do not need to. Okay, reversal is not needed with neostigmine. Why? Because they are undergoing Hoffman elimination. Now coming to rocuronium. Okay, rocuronium. What I remembered in this is, okay, rocuronium. See, in Hindi, ro क्यों रहे हो? ठीक है, रो क्यों रहे हो? That means pain on injection. Whenever there will be pain on injection, patient will cry. Therefore, rocuronium के साथ क्या याद रखना है? It causes pain on injection. ठीक है, and it is least cardiostable. Please remember, it is least cardiostable and therefore it is avoided in cardiac patients. So rocuronium, दो वजह से रोएंगे. एक तो pain on injection and it should not be used in the cardiac patients. ठीक है, but it is an agent of choice for continuous infusion as there is no active metabolite which is seen with rocuronium. Is it clear? Is it clear? Now rocuronium के लिए दूसरा एक और चीज है, as succinylcholine was used in rapid sequence induction, even rocuronium, ठीक है, it is an agent of choice with rapid sequence induction. Remember, NTMR agent of choice for rapid sequence induction is rocuronium. ठीक है, okay, as in cases of the full stomach, emergency surgery or pregnant patients, obese and trauma patients, we use rocuronium. Is it clear? Is it clear? Now mivacurium के लिए I told you first, पहले it is metabolized by what? It is metabolized by pseudocholinesterase. Other drugs which I told you today, which are metabolized by pseudocholinesterase, remifentanil. I told you, no, all the esters, local anesthetic, except what? Except cocaine and succinylcholine. So please remember this. Okay, mivacurium, it is rapid onset, shortest acting, metabolized by pseudocholinesterase and therefore it is used in the daycare surgery. Okay? Is it clear? So mivacurium, atracurium, cis atracurium, rocuronium. Please remember all these drugs. Okay? So these were all examples of what? These were all atra, cis atra and mivacurium are example of benzyl isoquinolones and rocuronium, vecuronium. Vecuronium में क्या याद रखना है? Vecuronium steroidal, ठीक है, steroidal. It is metabolized in the liver. Remember, it is therefore not given in the liver failure patients. Okay, liver failure patients में it is not given because it is metabolized in the liver and excreted in the bile. It is not affected by renal failure. Vecuronium कहाँ हमें मिलेगा? हमें cardiac OTs में मिलेगा because it is cardiostable. Okay, because it is cardiostable. Yesterday I told you a drug which will be inducing agent which will be present in the cardiac OTs, that is etomidate. Yesterday I told you inducing agent, IV inducing agent, cardiostable, that is etomidate. A muscle relaxant is vecuronium. Is it clear? Is it clear? But it is not used for continuous infusions because of polyneuropathy. So vecuronium कहाँ यूज नहीं करेंगे? लिवर फेलियर के केसेस में. कहाँ यूज करेंगे? कार्डियक केसेस में. कंटिन्यूस इन्फ्यूजन शुड नॉट बी यूज बिकॉज इट कॉजेज पॉलीन्यूरोपैथी. और ये क्वेश्चंस पूछे गए हैं. इज इट क्लियर? डॉक्टर एस जी, डॉक्टर प्रज्ञा, डॉक्टर प्रभाकर, इज इट क्लियर? Any doubts in this? ठीक है. पैंक्यूरोनियम आई टोल्ड यू स्टेरॉइडल और इसमें वेगोलाइटिक एक्शन. पैंक्यूरोनियम में क्या याद रखना है? वेगोलाइसिस. उसकी वजह से हार्ट रेट इंक्रीज होगा. ठीक है. तो लॉन्ग ड्यूरेशन ऑफ एक्शन बट इट इज सिंपैथोमाइमेटिक है ना. वेगोलाइटिक सिंपैथोमाइमेटिक therefore increases in the heart rate and BP. Remember potent bronchodilator. What is intravenous agent of choice? Intravenous inducing agent of choice in bronchial patients. Yesterday I told you bronchial patients में, asthmatic patients में, I'm so sorry, asthmatic patients में IV induction agent of choice is what? Ketamine, because it is a bronchodilator. A muscle relaxant is pancuronium. ठीक है. तो लिवर फेलियर में क्या कॉन्ट्रा इंडिकेट है? लिवर फेलियर में, ठीक है, लिवर में वैक्यूरोनियम यूज नहीं करते और पैंक्यूरोनियम. इसमें सिर्फ एक डंडी लगा देंगे तो आर बन जाएगा. पैंक्यूरोनियम इज नॉट टू बी गिवन इन रीनल फेलियर. ठीक है. ठीक है. These are the questions which are asked. Is it clear? Is it clear? Now newer NDMR, that is Gantacurium or AV430A. ठीक है. Gantacurium और AV430A. Many questions are asked from this also. क्या है? It is steroidal. ठीक है. But onset, duration and offset is same as choline. It is short acting but it does not have choline like side effects. मतलब इसमें fasciculations, myalgias और hyperkalemia नहीं होगा. ठीक है. इसमें नहीं होगा. Remember it is metabolized by chemical degradation by giving exogenous cysteine. ठीक है. That is that is for Gantacurium. Is it clear? All these points you have to remember only. ठीक है. All these points you have to remember. Just remember pancuronium P, then उसके बाद R आता है. तो pancuronium should not be given in the renal patients. उससे याद आ जाएगा vecuronium liver patients में नहीं देना है. Now skeletal muscle relaxants, neuromuscular blocker का reversal के लिए क्या यूज करते हैं? neostigmine. ठीक है. तो neostigmine कैसे एक्ट करता है? It is achieved by increasing the acetylcholine concentration by using acetylcholinesterase inhibitor, because acetylcholinesterase was the one which was causing acetylcholine का क्या बोलते हैं, it was degrading acetylcholine into acetyl-coenzyme A and this. So therefore acetylcholinesterase inhibitor देते हैं, that is neostigmine. ठीक है. बट हमने देखा था ये जो NDMRs थे, they were blocking only the nicotinic receptors. muscarinic receptors को नहीं कर रहे थे. ठीक है. ठीक है. But whenever there is increased concentration of acetylcholine by neostigmine, there are muscarinic side effects. And therefore muscarinic side effects से क्या होगा? उसकी वजह से हार्ट रेट कम होगी, है ना. whenever acetylcholine is more, heart rate कम होगा because of muscarinic side effects, and therefore atropine or glycopyrrolate is added with neostigmine. Is it clear? Is it clear? Adrophonium, sensitive for reversal action of mivacurium. And remember Sugamadex. Remember Sugamadex. ठीक है. इसको क्या याद रखना है? इट इज गामा साइक्लोडेक्स्ट्रिन एंड इट इज अ सिलेक्टिव रिलैक्सेंट बाइंडिंग एजेंट एंड इट इज सिलेक्टिव फॉर रॉक्यूरोनियम. प्लीज रिमेंबर दिस. क्या करता है ये? रॉक्यूरोनियम को इनकैप्सुलेट कर लेता है एंड देयरफॉर द एक्शन ऑफ दैट इज degraded and it is cardiovascular stable and there is no need of anticholinergic administration. तो दो नए ड्रग्स, that is AV430A और सुगामा डेक्स, ठीक है, एंड सुगामा डेक्स. These you have to remember. Is it clear? ठीक है. And I told you earlier also this point, muscle relaxants in myasthenia gravis. Myasthenia gravis में क्या प्रॉब्लम होती है? Myasthenia gravis में क्या प्रॉब्लम होती है? Myasthenia gravis में they are antibodies against the acetylcholine receptors. ठीक है, तो ये जो रिसेप्टर्स हैं, एनएम रिसेप्टर्स हैं, these are occupied by the auto antibodies. तो क्या होगा? Patients are hypersensitive because as they are already occupied by auto antibodies, therefore they will be hypersensitive to NDMRs. क्यों? क्योंकि auto antibodies are doing the same thing. They are desensitizing these receptors against the acetylcholine, है ना? So already acetylcholine receptors are desensitized, therefore they are more sensitive to NDMRs, but they are resistant to depolarizing muscle relaxant because they cannot act on it. They cannot act on the receptors because they are occupied by autoantibodies, therefore they act as antagonists to it. Okay, so these are in myasthenia gravis. So that was all for today's class. Okay, on Tuesday at 4 p.m. we will have important anesthetic drugs part 3, in which I will be discussing about the opioids and pre-anesthetic medications which are used, and also the inhalational agents. Okay, this I will be discussing on Tuesday at 4 p.m. on the YouTube only. Okay, and please install the Unacademy Learning app and get the Plus subscription. The advantages I told you earlier in the class, and if you apply my code, that is Apoorva Live, you can get 10% discount on the same. And on the NEET PG, okay, on the YouTube we have NEET PG channel. Please subscribe to it, click the bell icon, like and share. Welcome Dr. Pragya. I hope the topic was clear. Dr. SG, Dr. Prabhakar, I hope the topic was clear. If any doubts, please ask me through the Telegram app. Okay, and use my referral code